So why is it important? Why have we taken time to go through all of this? Well, because it gives us an approach to the diagnosis and treatment. So the diagnosis of epilepsy. So epilepsy is diagnosed if one has at least 2 unprovoked or reflex seizures more than 24 hours apart, or they've got 1 unprovoked or a reflex seizure, and if there's a high risk of recurrent seizures in the next 10 years, or there's diagnosis of an epilepsy syndrome, or there's a single unprovoked seizure in a person with an increased risk of recurrence. So these are patients that may have had a previous condition like a TB meningitis, neurocystic psychosis, a stroke, a brain tumor, or traumatic brain injury. I just want to explain here. So a reflex seizure is a seizure. It's separate from a provoked seizure. So basically, if someone has a seizure as a result of flashing lights, then that can be a reflex seizure. Obviously, you still need to go and look through for any provoking aspects that might have caused that, but it suggests that that person's brain is predisposed to developing epilepsy and seizures, and therefore you could diagnose them with epilepsy with that reflex seizure. So how do you diagnose it? So often it's on clinically. So we do a history, we take a history, and then take a history of that history. All right. So there's a lot of it is very important to find out what's going on. We need to know what's happening with the seizures, what's happening in the person's life. Are there any triggering factors? Are there anything that could be making it they're more likely to have seizures? And then through our examination, we look through a whole lot of other aspects. So some of the investigations that are suggested, this is I looked through an up-to-date to see what else they might have kind of suggested there. So they suggested going through some blood tests to look for causes that might be kind of almost like a general approach. But obviously, if you've got a certain suspicion based on your history examination and initial investigations, you would pursue those investigation pathways. So they recommended doing a CUSP, calcium magnesium phosphate, full blood count, liver function tests, and then also doing a urinalysis, and especially considering a pregnancy test. And then in the standard treatment guidelines, they also spoke about looking for dangerous differentials. So prolonged QT syndrome can also present with syncope, and syncope in relation to exercise, loud noise, emotional distress. The syncope can occur whilst supine, and you need to suspect it if there's a family history of sudden death in young people. And here you'd need to do a 12-lead ECG and have a low index of suspicion. The question that often comes up is to CT or not to CT. So I put the picture here so that we can kind of have a look at it together. So in this hospital treatment, hospital level guidelines update, that's kind of what the picture says. So basically, the diagnosis is usually made clinically. We need to get our history, as we spoke about. We speak about the juvenile myoclonic seizures and absent seizures being difficult. And then here they also say patients with new onset epilepsy should have a CT scan, and this is essential in immunocompromised patients, but then other investigations as clinically indicated. So here I think it's something that we would need to consider, help to decide based on our history examination and initial investigations, if there's something that a CT would give us extra information about. Later on, they go to speak about if the changes in a person that's been diagnosed with epilepsy and now the seizure pattern is different, then it's a good idea, or you should do a CT. And if the seizures are occurring despite adherence and the diagnosis is unclear, you could also CT there. So you spoke about our kind of etiology of seizures, so they can be provoked and unprovoked. For provoked seizures, we want to consider aspects like infection, such as a meningitis, sepsis, encephalitis. For metabolic, we want to think about hypoglycemia, as well as hypo or hypernatremia and hypocalcemia. So remember the ABCs is airway, breathing, circulation, and then DEFG, which is don't ever forget glucose. So always check the glucose on a patient. Just in terms of the management of hypoglycemia, so there's a well kind of described table on how to approach it for different aspects. Something to go through in like one's kind of own time, but it can be divided into mild, moderate, and severe hypoglycemia, and there's a way to approach that. But basically, the summary is level 1 hypoglycemia is an HET of less than 3.9, but not requiring assistance from anyone else. Level 2 is an HET less than 3, but not requiring assistance from someone else and can take orally. And level 3 hypoglycemia is a level that's low of what, like, kind of any of those numbers, basically, but requires assistance of another. And here the person requires urgent action and IV management. So just the oral glucose options that we've got. So the kind of dosing recommendation that they've got there, the equivalent in grams of glucose could be 3 or 4 glucose tablets, a half a cup of juice or regular soda. Here the diabetics can have a sugar-filled drink, 2 tablespoons of raisins, saltine crackers, a tablespoon of sugar, tablespoon of honey or corn syrup, and 6 to 8 hard candies, if you've got those around. So then we can consider other provoked causes, could be neurovascular, such as a stroke, or post-stroke sequelae, intracerebral bleed, brain tumors, and hypoxia. Cardiovascularly, we need to consider hypertensive emergencies, as well as the encephalopathy leading to seizures, and again, remembering our eclampsia. Trauma, we speak about our bleeds. And then it's always important to think about withdrawal, and this is why kind of taking the history is very important. So withdrawal from alcohol or benzodiazepines, or even defaulting or sudden withdrawal of anti-seizure medication can also cause seizures. With alcohol, we often think about and talk about delirium tremens. And while there are different time periods, they speak about the seizures typically starting between 48 and 72 hours after the person's last drink. But again, this varies. And it's, again, something to have a kind of a low index of suspicion for in an inpatient. So, for example, when I was working in orthopedics, there's a guy there that is a few days and suddenly just started having fits. And then you go and you kind of ask a bit more history, and he was a heavy alcohol abuser and ended up having delirium tremens, and we had to sort him out in the ward. Okay. Then could also be medication related. So it could be the medication that they are on, this anti-seizure medication. So this could be subtherapeutic. They could be in a toxicity range, and they could have been started on a new drug that's causing drug-drug interactions. Toxins and overdose are a big kind of dangerous aspect that could be occurring, leading to provoked seizures. So here, overdose in treatment, like isoniazid and amitriptyline, are very dangerous aspects. Okay. And then other aspects are toxins like cocaine, amphetamines, marijuana, heroin, and I put it right at the bottom there. I know a lot of us kind of live and have our blood mostly full of caffeine, but they said it's unlikely. See, we've got a person in the room taking sips of coffee, maybe, yeah. And maybe just a special kind of mention, there's a study done on a whole lot of toxin-induced seizures, where they found that things like stimulants and diphenhydramine would often lead to brief self-limited seizures, but the kind of substances that would lead to seizures and death would be the cyclic antidepressants, as well as cardiac depressant antiarrhythmics and theophylline. So remember, we have quite a lot of patients that are on or have access to amitriptyline, and amitriptyline can cause seizures and death. So this is an important one to look at. Just going back to this page again, overdose, isoniazid. So remember, anyone that's on TB treatment, that's getting INH, or anyone that's on INH prophylaxis therapy, or anyone that's attempting suicide, could use someone's treatment that's in their house. And isoniazid causes refractory seizures. Refractory seizures that are very dangerous. There's often a whole lot of other aspects that are also going on, and the treatment for that, or at least the antidote, is a gram for gram dosing of pyridoxine. So often, and if you don't know how much INH they've taken, you give 2 grams of pyridoxine orally or crushed through a nasogastric tube. And this is why it's important in casualties, emergency settings, to have a big stash of pyridoxine, ideally in a pre-measured 2-gram pack that you can give. So there's mimics. There's other mimics and things that we need to differentiate from. So anything that could be causing collapse, movement disorders, mental health conditions, sleep-related conditions, and migraine-associated disorders. So if you've got a migraine and you've got a visual disorder, it could be looking like a focal seizure originating from the visual cortex. Just a quick note on the mental health conditions here. We talk about psychogenic non-epileptic seizures. So this is often called a pseudo-seizure. And I think the term pseudo-seizure sometimes makes us as healthcare workers think this person is faking it. But I think that's quite unfair. And unfortunately, that can steer us away from searching for the deeper and more kind of sinister cause that we need to look for there. So psychogenic non-epileptic seizures are seizures. And while there might not be an epileptic diagnosis, we need to find out what is happening there. There may be severe stress in their life. They may not be aware of the seizure activity coming on. And there's a whole lot of other aspects that we really need to kind of go down that path to look for. So again, There's a lot of things that we need to consider in for our epileptic seizures, and this was specific for adolescents and adults. Again, you can see we're going through the pregnancy related infections, substances and poisoning, metabolic conditions, our systemic disorders, and primary cerebral diseases, which we've covered on a fair amount already. The standard treatment guidelines then go on to speak specifically about adolescents and young adults and why this is a difficult group to treat sometimes. Here there's an increased substance use and substance withdrawal problems, as well as head injuries. There's high prevalence of mental health conditions that may present as epilepsy imitators. And idiopathic epilepsies may first present in this age group. And these ones are the ones that one really needs to be thinking about, because they obviously, it's an idiopathic epilepsy, so you might not be finding a provoked cause. So it can be a bit more nuanced to find the diagnosis. There's a higher risk for poor adherence in this group, and it's important to have an intensive individual and family counseling and support for these patients. They also speak about the age group older than 65. They speak about the more common reversible conditions that are occurring here, like metabolic causes, medications that they're on, and alcohol withdrawal. There's also a risk of epilepsy. The risk of developing epilepsy increases with age, and they attribute this to brain tumors, to strokes, and to dementia. Again, we've spoken about the women of childbearing age. I just had it here, so it's part of our flow. But the other thing that I want to include here is that there's actually a SAPRA kind of valproate annual risk acknowledgement form. So there's a form that if the patient has to, for some reason, stay on sodium valproate, or there's there hasn't been a way for the medicine to be changed, this form needs to be filled out every year to explain about what's happening, what's the concern, and acknowledgement by the patient that there's a risk of teratogenicity to their child. So I think this is seeing a legal thing. Doctors get very nervous seeing very legal things. I think this is just another thing to kind of hammer home the fact that we need to do our best to individualize our therapy, try to meet them where they are, and try to give them the best, safest treatment that they can. Chronic management of seizures, right? So it's nice to think about non-pharmacological management and pharmacological treatment. Non-pharmacological, for all of them, we need to